Welcome back. We're here for lecture 23, where we're going to start focusing on some connective tissue diseases, in particular, Dupuytren's contracture, de Quervain tenosynovitis, and trigger finger. So to start with Dupuytren's contracture, this is a painless flexion contracture of particularly the medial or ulnar-sided fingers at the MCP joint. And you can see certainly in this person's hand, you see sort of this cord or band of connective tissue here, which is causing this finger, the fourth finger, to start flexing. This is somebody actually who would not be able to extend that fourth finger all the way and get it flat on the table. In this example, they are extending as much as they possibly can. It's caused in part by proliferation of some of the connective tissue of the palmar fascia. The palmar fascia essentially being connective tissue that's just underlying the skin. It is above the muscles and the tendons of the flexors, but because it does connect to them to some extent, that proliferation of connective tissue does cause this flexion contracture of the joints themselves. It's most common epidemiologically in men of Scandinavian or Northern European descent. It's usually a little bit in middle to older age, after age 40. But in particular, again, it's associated with Norway, Sweden, Finland, Denmark, the Scandinavian countries, and people who are descended from those particular countries. In Dupuytren's contracture, as we mentioned before, it's really a proliferation of this palmar fascia. That palmar aponeurosis, as it's being described here, overlies the different flexor tendons. It overlies the muscles there. It's providing some of the structural support to the skin of the palm of the hand. And here actually you see the hand in cross-section, and you see the palmar aponeurosis here colored in red. That again is this primary tissue that starts to thicken, starts to proliferate. It does also have a bit of necrosis. Remember, necrosis again is essentially cellular death. That's not caused by a normal programmed cell death, but cell death caused by other causes. And with that thickening, because it is overlying those tendons, it can cause some shortening, and that's what's leading to this essentially permanent flexion of those joints. The treatment of Dupuytren's contracture is mainly focused on quality of life. You can imagine that if this is a painless flexion contracture, that there's not really a complaint here that the person has pain or anything like that, but it's more a quality of life issue, that this person, because they're starting to have this flexion contracture, not only from a cosmetic standpoint, but also just the function of the hand starts to be limited depending on the severity of that contracture. Radiation therapy is one of the mainstays of treatment here, and you can see this is actually somebody who's being queued up for radiation therapy. They've had their hands labeled basically with where some of the different cords of increased connective tissue are, where some of the nodules are that are within that palmar fascia, and essentially the outline that you see here on the outside, that's basically where the radiation therapy is going to be acting. So you see here's an example of somebody's hand actually within one of these radiation machines, and it's using a beam to essentially direct that radiation to particular sites to be able to break down some of this excessive connective tissue. In addition to radiation therapy, there are injections of collagenase, which essentially, collagenase helps to break down collagen. Collagen is one of the main proteins of connective tissue. The brand name for collagenase injections is mainly Xiaflex. Hand surgery may also be used. Now, we tend to avoid hand surgery unless it has to be done. This would be somebody who, despite having done radiation therapy, despite having done the collagenase injection, still has that flexion contracture, and it's significant enough to impact quality of life. You can see here that they've had to open up the hand. They've removed some of that palmar fascia and closed it back down. There may also be a needle aponeurotomy performed. This essentially is a needle that goes in and it cuts through that aponeurosis or palmar fascia to help to release that flexion contracture. For de Quervain tenosynovitis, this is also referred to as gamer's thumb or mommy thumb, and it has to do with essentially where it's created or what causes de Quervain tenosynovitis. It's generally due to an overuse injury, and in particular, it's an inflammation of the sheath around the extensor pollicis brevis and the abductor pollicis longus tendons. Remember, those two muscles contribute to the anatomic snuff box, and actually you can see, it may be called mommy thumb, but here I guess we're going to call it daddy thumb for a moment. One of the main causes for it is actually holding babies. Then in addition to holding this way, where you can see there's a little bit of bulging here that's been labeled, of the extensor pollicis brevis and abductor pollicis longus tendons, you can see that little bit of bulging here, but essentially that's paying tribute to the fact that if you're lifting a baby for months on end, that you do have a bit of overuse to that particular tendon or group of tendons. In addition to lifting in this fashion, certainly holding a baby and supporting the head as well can cause some additional stress on that lateralmost portion of the hand, again overlying that abductor pollicis longus and the extensor pollicis brevis tendons. So the main findings that we'll have then are pain over that anatomical snuff box, and the person may also complain of some difficulty gripping. In particular, the thumb here may have some weakness because the two muscles that are being affected are two muscles that act on the thumb itself. You see here for de Quervain tenosynovitis, we are looking a little bit at the anatomic snuff box. As we said from before, it's the abductor pollicis longus and the extensor pollicis brevis tendons that are most affected. And remember, that forms one border of the anatomic snuff box, the other main border here being the extensor pollicis longus. Remember, under that anatomic snuff box, we can find the scaphoid bone, one of those carpal bones, and during a scaphoid fracture, we would also expect to have pain in this area. So the differential diagnosis for de Quervain tenosynovitis, in addition to that possible diagnosis, would be a scaphoid fracture if somebody had a history of trauma or falling on an outstretched hand. You see the anatomic snuff box also illustrated over here with the extension of the thumb that the person's performing here. You can really highlight that extensor pollicis longus tendon, as well as the tendons of the extensor pollicis brevis, and though not labeled, we would also have the abductor pollicis longus next to that extensor pollicis brevis. And then down here, again, more schematically, we see those same tendons contributing to the anatomic snuff box, which they've labeled here. And remember, in addition to that scaphoid bone, we actually do have a portion of the radial artery also running through that anatomic snuff box. The diagnosis of de Quervain tenosynovitis is mainly based on some of the history and physical exam findings. In addition to this history, often with an overuse injury, in, say, a woman who has recently had a child, or the father of a baby who's been doing a lot of lifting, or we mentioned before, gamer's thumb. People who play a lot of video games can also end up with the same kind of overuse injury. In addition to that history, we'll also do a physical exam, and in particular, Finkelstein's test is often used to help diagnose this de Quervain tenosynovitis. Finkelstein's test is being illustrated over here in the picture, and essentially what we're doing is we're placing stress onto the extensor pollicis brevis and the abductor pollicis longus tendons by essentially forcing a bit of an ulnar deviation to the wrist, which again will stretch those tendons and should cause pain in somebody who has de Quervain tenosynovitis. We may try to accentuate this a little bit more actually by asking the person to put their thumb into their fingers and then doing that ulnar deviation. That can cause even some additional stretch onto those tendons, so that's even a little bit more sensitive than the way it's being shown here. The treatment for de Quervain tenosynovitis mainly is rest, usually using a splint. Steroid injections may also be used to help reduce the pain and swelling or the inflammation within that area, and NSAIDs, of course, as pain relief can be one of the mainstays of therapy too. So let's take a look then at trigger finger. Trigger finger is a catching, a popping, or a locking of the flexor tendons under the first annular pulley. Now, the first annular pulley is a portion of the metacarpophalangeal joint. It helps to essentially hold the flexor tendons in place as they're passing into the finger. And essentially what happens here is we have a bit of a nodule in that flexor tendon. It's getting caught at that first annular pulley, causing this what's referred to as a flexion deformity within the finger. But this can at sometimes spontaneously release as that nodule finds its way under the annular pulley and allows extension. And so what would happen is the person here has that locking sensation, it feels stuck, and then all of a sudden it'll be able to suddenly release spontaneously, and that's the trigger effect that's being described here. In addition, they'll have associated pain because we're essentially trying to force a nodule through a small space. That's going to cause some pain, and they'll also have dysfunction of the joint because of its limited mobility. Usually, as I said, this is caused by a nodule or some inflammation of the flexor tendon. This means that essentially we're trying to force something that's too large through that annular pulley. It gets caught, and then again, when it spontaneously releases, we get that trigger effect. So here you see a little bit of the relevant anatomy. In particular, we're talking about the flexor tendons. Remember, the flexor digitorum superficialis and profundus are going to pass through this area that is essentially the annular pulley. The annular pulley here has been essentially cross-sectioned, but you can imagine if this was wrapping around that tendon, and if we had a nodule within that tendon, it's going to have difficulty sliding through that annular pulley and being able to release and allow the finger to fully extend. Over on the other side, you see a little bit more detail of some of the ligaments that are involved within the finger. But again, you can see in this diagram below, we see that annular pulley, and we see essentially some of the tendons trying to pass through this area. You see the flexor digitorum a little bit below, but what's been removed here is essentially a larger portion of this annular pulley that would be wrapping around that flexor tendon there. So for treatment of trigger finger, treatment of trigger finger, the primary mainstay are corticosteroid injections. You've seen this used in a lot of the other diagnoses that we've discussed, but that's because most of these diagnoses do have accompanying inflammation. Being able to inject that particular area with the corticosteroid reduces that inflammation, can mean that the nodule itself gets smaller, and therefore we end up with less of this triggering effect and certainly less pain and dysfunction. In addition, NSAIDs are a mainstay of therapy, as pain relief is certainly one of the primary motivations to treat the people here. And trigger finger release surgery may also be done. This is usually only done again in refractory cases, but we have basically a pulley release surgery that's being done. You can see in this example here, this is a congenital trigger thumb. So this is actually a very young child here, but essentially you can see that we've opened at the metacarpophalangeal joint. We have isolated the flexor tendon here, and prior to actually having isolated that flexor tendon, they would have had to go through that annular pulley to be able to release. Therefore, if we did have a bit of a nodule or a shortened tendon, we won't have as much of an issue anymore with it trying to get under that annular pulley. So that's trigger finger, as well as de Quervain tendinocinivitis, and we talked about Dupuytren's contracture. In the next lecture, we're going to move to some limb deformities and start discussing the embryology and development of the upper limb. See you then.